All right. Thanks so much for having me today. I'm going to be talking about classification of anxiety disorders with the provocative does it matter question mark on there. I was inspired to talk about classification after Jimmy's first grand rounds of this year, which dealt with classification, including the upcoming DSM-6. I say upcoming, I imagine it's upcoming. I have no idea when. It's also inspired by Angela's excellent discussion of the new DSM-5 diagnosis of avoidant restrictive food intake disorder. But classification, as Jimmy mentioned, is a long-term interest and something we've studied and informed using epidemiologic and genetic epidemiologic data over the years. So I have no relevant financial relationships to disclose. And here are the objectives for today. My main focus will be on the history of anxiety disorders classification, topic I've thought and written about quite a lot. This talk is adapted from a course we gave at the APA meeting in San Francisco earlier this year. It is largely of theoretical interest, but I hope also of practical interest to you guys. So I'll spend a lot of time on the history of anxiety disorders classification, as I said. And I'd like us also to consider how anxiety disorder diagnoses may matter for conceptualization and treatment, whether or not the anxiety disorder is the focus of treatment. So when I talked about the history of anxiety disorders classification in the past, I would start with William Cullen and his coining of the term neurosis in the late 18th century. But I was inspired by the work of a French psychiatrist and linguist called Croc, cited here on this slide, to go back to the beginning of clinical medicine and Hippocrates. So Hippocrates is known as the father of clinical medicine because he used a scientific approach to health with careful observation, and he did not attribute all illness to divine intervention. He and his acolytes produced a body of work called the Hippocratic Corpus. These early physicians attributed all illnesses to the balance of the four humors and bodily fluids, or bodily fluids. They did dissect non-human animals as well, and tried to understand human anatomy and, very crudely, physiology. But of course, they had a relatively limited understanding, and they only counted 4 elements in the world. Treating imbalance of the humors involved purgatives of various sorts and bloodletting, and this was the dominant form of medicine for millennia. 2 sections of the Hippocratic Corpus in epidemics mention a couple of men with what are usually these days considered phobias. These men were Damocles and Nicanor. This is significant because these very brief case histories appear in a text of medicine, at the time presumably examples of melancholia. So Damocles had a long-term fear of walking along the edge of cliffs or over bridges. So even a short bridge or a bridge over a relatively shallow ditch, he would walk through the ditch rather than cross the bridge. And not a lot of explication there. They're just case histories. Again, it's important to emphasize that the humoral theory of disease, with its requisite treatments, lasted around 2,000 years. Galen, shown here, is a Roman Greek, and he was incredibly influential as a scholar and physician. He also idolized and promoted Hippocrates' work. His ideas about medicine were only gradually rejected toward the end of the second millennium. In Galen's time, moods were believed to be influenced by the balance of the humors, and Galen added to this understanding by introducing the concept of temperament. It is striking that we still talk about melancholia or black bile today, in that there is no such bodily fluid. In preparing for this talk, I came across an article by, I believe, a dermatopathologist with a lifelong interest in linguistics. His name is Dirks. I have him cited here. I admit that I was curious what black bile was, and found this on PubMed. And Dirks made many excellent points in this little article. But one was that humoral theory was reified for so long because of its simplicity, symmetry, and elegance, corresponding to the known elements, earth, fire, water, and air, as well as correspondence to the four seasons. It's important to note that many question the assumptions of this humoral theory over the years, including if you give something to induce vomiting, that is a drug or piece of bark, etc., and it causes black vomit to come out. It doesn't mean that you're actually expelling black bile, that is the bark, the drugs, etc., could be causing the vomit to turn black. But I think, like so much in our world, we continue to believe things that seem right. So this French linguist and psychiatrist Croc also discussed the classical Greco-Roman scholars and philosophers, including the brilliant statesman, orator, and neologist Cicero. Cicero was not a physician himself, but he spoke of anxiety as an illness, and he specifically made use of the Greek word for illness or disease. He also created a word for proneness to anxiety or trait anxiety. And as Jimmy mentioned, I have a lifelong interest in personality traits and temperament. So I was a little bit surprised by some of these things. So Cicero was a Stoic, and in his written work, Tusculan Disputations, he written after the loss of his daughter Tullia, he makes the case for Stoicism. But he talks a lot about affects, including anxious affect, which he differentiated from sadness. And he spoke of worry, solicitudo, and noted its relationship to negative thoughts, etc. He spoke of anxiety or anger as a medical illness, and noted that anger was a constricting emotion. Again, he also discussed trait anxiety or anxietas. And though Epicureanism and Stoicism were considered kind of dueling schools of philosophy, it's remarkable that both schools offered similar advice regarding achieving euthymia or tranquilitas. So Epicurus, Cicero's the guy on the top. Epicurus is the severe-looking guy in the middle. He said that the objective of a happy life is to reach a state called ataraxia or serenity. And I can't help but agree with him. And he said, the way to do this is to be rid of negative thoughts about the past and fears about the future. Seneca, also a Stoic, wrote in his work of Peace of Mind that one should focus on the present, not the future, particularly not focusing on the inevitability of death. And in preparing for this, I realized that Seneca was forced to commit suicide by the Emperor Nero. I don't know if it's really should be called suicide if you're forced to do it. So moving into the modern era, I would like to mention Robert Burton. And Robert Burton was a scholar at Oxford and became a lifelong fellow at Oxford. And he wrote this encyclopedic work, The Anatomy of Melancholy. And it covered from antiquity all the way to the 17th century. And so Robert Burton, I think he would say that he suffered from melancholy his entire life. So he was not a physician. But he found writing this work therapeutic. But in this very long, and I understand kind of hard to follow work, Burton dealt with both depression and anxiety, sorrow and fear, both together and separately. And I was very interested to learn that he talks about examples of performance anxiety, which I certainly identify with, going all the way back to antiquity, and specifically Cicero, who would tremble at the beginning of his speeches. In the 16th to the 18th century, there are many medical descriptions of what look like to us today panic attacks. And these were considered symptomatic of melancholia, or later vapors and melancholia. This term vapors is interesting. It sort of came and went. Later, the Boissier de Sauvage, obviously French person, wrote Nosologia Methodica. So he was a physician and a botanist, and like many at the time, was very interested in classifying things. And it's interesting that Boissier de Sauvage mentioned several kinds of anxiety in his classification. Hydrophobia had certainly been talked about since the ancients, and was, I understand, rather, the recommended treatment for hydrophobia was rather brutal and involved flooding, no pun intended, that is, throwing people into bodies of water and holding them under until they drank in water. In any case, he also spoke of panophobia, from the Greek pantophobia, meaning fear of everything. He talked about panic terror, which occurred specifically at night, as well as panophobia hysterica, or panic terror caused by vapors. And this was attributed to a diathesis of exacerbated sensibility. Symptoms included palpitations and/or pallor, and dramatic action when startled. So this doesn't really fit with any current psychiatric diagnosis. But it's interesting to note that it was described. Panophobia frontis is another condition described. And it is similar to generalized anxiety and depression to some extent. It involves a tendency to worry, avoid company, and complain of pain and bodily tension. So further on in the modern era, we're just now catching up to what I used to pay attention to with regard to the history of classification of anxiety disorders. So on the top right, we have a picture of William Cullen of Scotland, who wrote a nosology in Latin. synopsis, this synopsis that I mentioned here. I never studied the classics, and so I won't attempt to pronounce the name of his nosology. But as I mentioned, Cullen used the term neurosis, and he really coined the term neurosis. And so people often speak of the weird thing to us today that you couldn't really have a nervous condition until the late 18th century. But that's, of course, what neurosis means. But Cullen did not mean a neurosis in the same way that many of us today probably think of the term neurosis. Rather, he was talking about a syndrome of the nervous system that involved, specifically those affections which do not depend on topical affection of organs, but upon general affection of the nervous system. And Cullen noted that many, many medical conditions could be related to this. But some of his examples of neuroses include the comas, including apoplexy, which I would note can involve hemorrhage in the brain, which would be topical affection of the nervous system. The adynamias, or the difficulty with moving, weakness, etc. Spasms, which would include what we now call epilepsy, as well as this term hysteria, which had been talked about by millennia. I think Cullen did not think of hysteria as a wandering uterus, but rather as something that was related to nervous system function. And then Vesanius, the very old term for madness, which had been revived by Boissier de Sauvage. And it's interesting. So we have this term, and Cullen's work was quite influential. And so people ran with this term. And over the years, different things started splitting off of neurosis. In the middle of the 19th century, for example, we have psychosis used for the first time. And what's interesting to me is looking back, reading some of the history of the use of these terms, it's clear that people were all over the place in terms of what they thought the terms meant. And so psychosis was originally used to describe a change in a person's entire personality, not just not what we think of today with regard to specific kinds of psychiatric symptoms. But back to anxiety disorders. So I mentioned many things were split off from the neuroses. Certainly conditions that were eventually shown to be caused by, for example, syphilis, general paresis of the insane. That would have been taken out of the neuroses. Epilepsy eventually would be taken out of the neuroses. Strokes, etc., would be taken out of the neuroses. But eventually the anxiety disorders were also removed from the neuroses or made into specific conditions. So one example from an American physician and neurologist, George Miller Beard, was neurasthenia, or nervous exhaustion, was the title of Beard's paper in 1869, Neurasthenia or Nervous Exhaustion, published in the precursor to the New England Journal of Medicine, the Boston Medical and Surgical Journal. And Beard was focusing on a set of symptoms which he attributed to modernity, with many people moving into cities, with women taking less conventional roles, etc. And he described this condition and had relatively conservative treatments for it. Interestingly, that did not involve bloodletting, etc. I should say that one of Cullen's pupils was Benjamin Rush, or the father of American psychiatry, who certainly did continue to use treatments for the humors. But Beard described neurasthenia as a group of symptoms involving fatigue, malaise, headache, neuralgia, hysteria, hypochondriasis, impotence, anxiety, and depression. And he recommended rest treatment. He recommended that people in cities go into the country and do something physical, outdoors, etc. And he also popularized the idea of mild electric current applied, I believe, to the hands as a treatment for this new condition, neurasthenia. And it was really thought to be related to and really a depletion of nervous energy. And it was quite influential. So some further splitting of neurosis. I make all the residents, I apologize, but I make all the residents read this paper by Peter Tyrer called Neurosis Divisible, published in Lancet back in 1985. I like the paper because it focuses on the fact that so many things that we call neurosis, that used to be called neurosis, have been split apart. And it gets away from the idea that these things have something in common, something shared. So Westphal, for example, coined the term agoraphobia, literally a phobia of the marketplace, or fear of the marketplace. And I think to really understand agoraphobia, you have to imagine that the marketplace is quite crowded with other people. To this day, agoraphobia is understood as a condition of anxiety when a person is in a situation from which it's difficult to escape quickly or without a lot of embarrassment. Anxiety neurosis. We've all heard of Sigmund Freud, of course. He is the person who coined the term anxiety neurosis. And it's interesting that the title of his paper, he mentions removing anxiety neurosis from neurasthenia. That's how influential it had been. And then there were the specific and social phobias. Like I mentioned, phobia of water had been described for millennia, but a couple of French psychiatrists and psychologists and Isaac Marks really at the Institute of Psychiatry really got people focused more on these conditions, their similarities and differences. So Hartenberg was a French psychiatrist who wrote an early work on social phobia or shyness, which is quite prescient. And there's obsessive compulsive neurosis, described by Janet, although certainly Kraepelin made note of this condition, as did Westphal in Germany. We've got the milder depressive states described by Aubrey Lewis. I have to admit, I didn't realize Aubrey Lewis's connection to Johns Hopkins, having seen him on the wall in our Phipps library. But Aubrey Lewis was here working with Adolf Meyer in the mid-1920s. And finally, panic disorder, a diagnosis really put on the map by Donald Klein at Columbia. And it's interesting thinking about how this came about. At the time, Klein and his colleagues were using imipramine as a treatment for what they diagnosed as schizophrenia, maybe pseudoneurotic schizophrenia. So this was on inpatient services. And what Klein noticed was that a certain group of patients stopped running up to the nursing station all the time on imipramine. And so he got very interested in the phenomenology and eventually separated panic disorder from the rest of what was called anxiety neurosis, again, Freud's term. And he thought that panic disorder was specifically responsive to imipramine, while generalized anxiety was only responsive to benzodiazepines. Of course, that would not prove to be true, but it does not take away from the importance of describing panic disorder. So this table summarizes all of the DSM neuroses and anxiety disorders over time. So Jimmy talked about this during his grand rounds. The original Diagnostic and Statistical Manual in the 1950s, a time when psychoanalysis was quite popular in the United States. Nevertheless, the psychoneurotic disorders, their name was heavily influenced by Adolf Meyer. That is, they were phobic reactions, anxiety reactions, obsessive compulsive reactions, and then these other things, which have long been gone from the anxiety disorder section: depressive reactions, conversion reactions, and dissociative reactions. So DSM-2, the term for these conditions changes to neuroses. And I should say these are differentiated from so-called organic brain diseases and psychoses, which included manic depressive illness and schizophrenia. And they also were differentiated from personality disorders. So the names changed from reaction to neurosis, and more neuroses were included, including hysterical neurosis, which is just kind of interesting that it kind of reappeared. I just think of it in terms of somatoform symptomatology. Neurasthenia makes its comeback here. And then we have hypogonadal neurosis, another somatoform condition, and depersonalization, another dissociative condition. By 1980, when DSM-3 came out, we had much more elaboration of the anxiety disorders, probably in large part because Robert Spitzer was at Columbia, where a lot of work was being done on the anxiety disorders. So different kinds of phobias spelled out with explicit diagnostic criteria, improving reliability of diagnosis, etc. So we had agoraphobia with and without panic attacks, social phobia, simple phobia, with lots of different examples of simple phobia. The former anxiety neurosis was split by Donald Klein, as mentioned earlier, and there was this residual thing characterized by chronic free-floating anxiety called generalized anxiety disorder, or GAD. There was obsessive compulsive disorder now, and post-traumatic stress disorder was introduced at that time after the Vietnam War, though recognized by other names since at least the time of World War I. DSM-4 not much changed with the anxiety disorders. But again, the somatoform disorders, milder depressive conditions, unipolar depressive conditions, had long been moved out of that section. and acute stress disorder was added. So thought to be useful because patients with severe acute PTSD symptoms seem to be at higher risk for long-term PTSD symptoms. And then DSM-5. There are a few changes with DSM-5. One, which I think is quite reasonable, is that agoraphobia was separated from panic disorder. It's quite clear that agoraphobia and panic disorder are related. But agoraphobia had gone from being the title of chapters in psychiatric textbooks to a thing that was virtually always caused by panic disorder, such that it became really hard to even study agoraphobia by itself. Other changes in DSM-5, selective mutism, which is thought to be related to social anxiety disorder, particularly in children, was added to the anxiety disorder section. And separation anxiety disorder was moved to the anxiety disorder section. People may note that these symptoms can certainly persist into adulthood. So I've been talking about splitting of neurosis, as decried by Tyrer in his paper, Neurosis Divisible, ? I find work that really focuses on what is shared by the conditions particularly interesting. So when I was a fellow, Robert Kruger published an analysis of the National Comorbidity Survey data in Archives of General Psychiatry. And all he did was look at psychiatric diagnoses in terms of what is most correlated with what. So he used factor analysis, which had been used for many years to study personality traits, for example, just by looking at correlations, trying to understand higher order factors. And so we're used to thinking of this in terms of syndromes, but he's looking at collections of syndromes in this case. So he used all of the most common mental illnesses measured in the National Comorbidity Survey and asked the question, do these seem to be a single entity or a couple of entities, or this final model that he came up with, which involves internalizing and externalizing symptoms. Going back in time, one might think of the internalizing symptoms as symptoms of melancholia or neurosis. And of course, the somatoform disorders were not mentioned or not measured in the National Comorbidity Survey, or not measured well, or weren't very frequent. Kruger divided up the anxiety and depressive disorders into two factors: anxious misery and fear. And there's no doubt that generalized anxiety disorder is quite strongly related to major depression. But he was using the terminology from the child psychiatry literature to describe these factors. It was thinking, shouldn't we be looking at what causes these conditions might share, and might this frequent comorbidity possibly inform treatment of conditions which are similar in some ways? So there have been at least two large studies asking the question, why do conditions tend to co-occur, using genetically informative data, in particular twin data. So here is a paper by Kendler and colleagues published a few years after Kruger's paper, with a proposed structure for the genetic risk factors for common psychiatric or substance use disorders. So Kendler noted that Kellner and colleagues found that it was really the genetic factors which seemed to group these things together most strongly. Interestingly, he found that for both alcohol dependence and other drug abuse or dependence, there were disorder-specific genetic factors that were detectable with this complicated statistical modeling. And an even more confusing diagram, which I'd like to talk with you guys about, so the previous study had used data from the Virginia or Mid-Atlantic twin sample. And this particular paper used data from a Norwegian twin sample in which the Norwegians were measuring axis 1 conditions as well as all of the personality disorders. This is the structure of genetic and environmental. Look, this slide is particularly genetic risk factors for syndromal and subsyndromal DSM-4 axis 1 and all axis 2 conditions. Here in the top left, all of the so-called internalizing disorders loaded on a single factor, eating disorders, which were grouped together, loaded both on an internalizing factor as well as an axis 2 externalizing factor. Somatoform disorders loaded on this internalizing factor and also had a substantial independent contribution from an axis 2 internalizing factor. And it's interesting to look at what's in this axis 2 internalizing factor. So dysthymia appears there. Social phobia appears there. Conditions which had been thought of as axis 1 conditions. And we've got avoidant and dependent personality disorders, not surprising. Schizotypal and schizoid personality disorders, maybe not surprising. But obsessive compulsive personality disorder appears out here in externalizing conditions. I definitely would not have expected that. So I'd like to finish up that's my explication of kind of the history of anxiety disorders, nosology, and comorbidity, etc. I'd like to mention some ways in which anxiety disorders are important. We all know that anxiety disorders are the most common mental illnesses worldwide. So they're important because they affect so many people, even if we psychiatrists are not the most likely people to treat patients with non-comorbid anxiety disorders. They increase the risk of suicide quite substantially. The anxiety as a symptom, as well as anxiety as a diagnosis, increases the risk of suicide. And when anxiety disorders are comorbid with major depressive disorder, they make major depression tougher to treat successfully. So this is a graph on the right from the Ph.D. study showing that patients with anxiety disorders, comorbid concurrent anxiety disorders, plus or minus substance use disorders, had delayed recovery compared to patients with neither comorbidity. And the same thing was found when studying other drugs in the Ph.D. study, including bupropion and venlafaxine and sertraline. This is a very busy slide. I just want to make the point that anxiety disorders treatments really overlap a ton. And they overlap also with mood disorders, well, particularly depressive disorders treatment. And the treatment of some somatoform conditions. So SSRIs, or just plain serotonin reuptake inhibitors, help most of the anxiety disorders. And the the benzodiazepines are still used to some extent with patients with panic disorder, social phobia. They are very good drugs for reducing physical symptoms of anxiety. They're very very strong negative reinforcers. In terms of psychotherapy, there's also a ton of overlap with the other former conditions lumped together in the neuroses or melancholia, particularly exposure, but also other parts of cognitive behavioral therapy, anxiety management, and cognitive therapy. So I want to conclude here and say that anxiety disorders are descendants of melancholia and neurosis. They are very highly comorbid with each other and other internalizing conditions, including depressive disorders and somatoform disorders, to a lesser extent, substance use disorders. And as I said with the last slide, treatments for anxiety disorders overlap to a large extent with treatments for depression. The focus in psychotherapy, for example, cognitive behavioral therapy, varies. I will stop sharing. Thank you very much.
Thank you, Joe. That was awfully interesting. One of the things that kind of historical view always makes me think about is the fact that clearly some very smart people have looked at this issue over time. And the result is that people keep changing their conception of how to think about these illnesses, which creates a certain amount of humility, I think, from my perspective. That is to say, it probably means that just like nobody else seems to have felt like they got it quite exactly right, we probably haven't gotten it exactly right now either. which leads to the question, do you have any sense of where this is headed? I mean, what do you think people will be saying 25 years from now? In what way do you think this is evolving, and what new directions might come up as time goes on?
That's interesting. I think, we often talk about the fact that that there haven't really been a ton of new medications. So many of the medications that we use for anxiety disorders were sort of stumbled upon by accident. I shouldn't say anxiety, all psychiatric conditions have been stumbled across by accident, but it's certainly possible that that we will be smarter about developing treatments that improve the efficacy of exposure therapy, for example. People for a while were focusing on D-cycloserine as a potential medication used to treat tuberculosis, but that enhanced extinction learning. I'm not quite sure where that research is now. Mm-hmm. I think there certainly are also trans-diagnostic cognitive behavioral therapies that people have worked on that make sense. I forgot to say, I saw Bill Eaton was here, and I did my fellowship with him. He made the point, which I forgot to make during the talk, that we clinicians tend to like to focus on a single diagnosis when comorbidity is really the rule, especially if you're talking about in specialty care. So these trans-diagnostic approaches make sense. That's about as far as I can go.
Okay, thanks. Well, Netta Gould says, fantastic presentation, Joe. I was struck by the Greco-Romans view on serenity. Be rid of thoughts about the past, fears of the future. It sounds a lot like mindfulness.
Yes, and I don't know about you, Netta, but I consider mindfulness, I kind of lump it in with cognitive behavioral therapy. Be interested to hear what you say.
Yeah, I agree, and I think there's such a nice overlap with those two things when they work synergistically together for a patient. So they're aware of their thoughts, but they don't get consumed by them, and then we're able to modify the thoughts. So it's a really nice synergy when it works. So thanks, Joe.
Thank you, Ned.
Well, let me ask you this, Joe. The other big thing I was thinking about was the whole issue of the implications of lumping versus splitting for treatment. And you touched on that towards the end. And I guess I often make the point, when we're treating someone for depression, we're choosing a medication for depression, and someone says, oh, well, they also have anxiety. And the obvious point is, well, our medications for depression typically are good medications for treating anxiety as well. And so in that sense, the lumping kind of points you in the direction of, okay, the same medicine treats all those things you've lumped together. Of course, that's one slice, that's one angle on it. But are there other ways in which you think lumping versus splitting are more or less useful from a treatment perspective?
Thank you. Yeah, this is something we used to debate in our anxiety disorders clinic back when Rudy Hernser was still here, and Una McCann and Jim Fauerbach would come over to help teach our residents. It was after you were a resident, Jimmy.
Uh-huh.
But I think you make a very good point that certainly the so-called antidepressants are first-line treatments for anxiety disorders. I tend to think of, I don't tend to start patients on bupropion if they have a prominent anxiety disorder, particularly if they have panic disorder. Patients with panic disorder are so sensitive to side effects. And bupropion can be quite activating. I don't say never use bupropion in patients with anxiety disorders. I just think it's not a great first choice. Whereas the SRIs have the most broad efficacy. So if a patient has social phobia and or obsessive compulsive disorder, it gets you thinking about what antidepressant to use, and also with OCD, how high the dose might be, and how quickly you should go up before waiting to see if it's going to help.
Mm-hmm, mm-hmm.
But the psychotherapies, there are some things which are in common, but there are also some things which are quite different for treatment of the different anxiety disorders. And so, like treatment of specific phobia of elevators, for example. I remember one time Jim Fauerbach was treating a patient with really claustrophobia. And he was very nervous in elevators as well as, I think, in a dentist chair. And so the exposure involved having all the residents surround his chair as he was sitting in it. And then very shortly after that, going to an elevator. And to Jim's surprise, he got on the elevator. Jim was just bringing him there as a kind of a behavioral exposure. But he was basically cured after that day.
Wow.
Whereas, conditions like panic disorder, agoraphobia, social phobia tend to be more long-term treatments, tend to be required. But they have to be modeled on basically what the person's fearing, what they're avoiding, etc.
Wow, that was a dramatic cure. Huh.
Yes.
Interesting. Bill Narrow says, great talk, Joe. What are your thoughts about generalized anxiety disorder? Is it a real diagnosis or just an aspect of major depressive disorder? Similarly, PTSD, could it be grouped with another anxiety disorder or depressive diagnosis?
Yes, and I think those are great questions and ones that I've definitely struggled with over the years. I partly believe in generalized anxiety disorder because I, diagnosed myself with it, but I don't think I've ever had a real major depressive episode. But I think they're clearly quite strongly related. In these twin models, they really don't appear separable in terms of their genetic underpinnings. And yeah, I know Dr. Treisman and I have discussed in the past how commonly patients with generalized anxiety disorder have particular kinds of personality traits that are strongly related to the condition. And I don't deny that, but I would say the same is true for most of the anxiety disorders. So I kind of like keeping generalized anxiety disorder in the nosology, because I think ever since the separation of panic disorder, people have wondered what to do with patients who are fairly prone to anxiety, particularly under conditions of stress, and have these symptoms of hyperarousal, et cetera. But post-traumatic stress disorder is another quite interesting one that has certainly gotten a lot of press. It's been studied a whole lot since 1980. But it is also a condition that's not just a response to a traumatic event. There's something about us humans experiencing the traumatic event, which is really important. And I think it probably has to do with personal meaning, as well as personality traits, as well as the setting the person is in after the traumatic event, et cetera. I kind of like PTSD being lumped with the anxiety disorders, and the same with OCD, just because the principles of cognitive behavioral therapy to treat them overlap so much with the anxiety disorders.
Well, the comments and questions have poured in. I hope we can get through some of them here. Let's see. Let me go to Peter Rabins, who says, are there biomarkers that can help distinguish among clinical disorders, or do they support the shared comorbidity hypothesis?
That's a fantastic question, and one which unfortunately I'm not that well prepared to answer. I think that someone smarter than me with neuroimaging would probably say that there are things that are shared with the different anxiety disorders upon exposure to a feared stimulus, et cetera. But I don't think they're great at differentiating. Maybe there are differences between anxiety and depression in terms of those things, but it's a good question.
Well, how about Jerry Nestat's question? Any thoughts about Kendler's study including OCD as an externalizing disorder? Could this be an artifact of diagnostic methods?
Gosh, I don't even remember that study.
Okay, we'll skip it then.
But I think people have tried to locate OCD within the structure of common mental disorders, and certainly I'm not talking about twin studies, just epidemiologic studies, and OCD is often loads on with the anxiety disorders, PTSD as well, and pathological gambling loads with the externalizing disorders, addictive conditions.
Well, let's see. Let me go to Roma Vasa. Hi, Joe. Fantastic talk. What do you think of someone with multiple phobias? Would you consider this a variant of generalized anxiety disorder because there's fear, worry about so many different stimuli and contexts?
Yeah, it makes you think of that French psychiatrist, panophobia, fear of everything. I think, the phobias are really interesting. Some of them, like the situational phobias, tend to have onset in adulthood, just like agoraphobia and panic disorder do. And they involve situations which together we call agoraphobia. But I think, this idea of comorbidity having meaning is important. Some things I didn't discuss, like disability and response to medications, really is sensitive to the amount of comorbid conditions. I mean, as simple as that. And so I'd have to hear more about the particular case, but I think it's interesting when you see these combinations to say, okay, well, this is more complicated.
Mm-hmm. When we go to Paul Nestat, what I like about Tyrer's model is he includes a time axis. Do you see that among anxiety disorders, comorbidities seem to wax and wane, take turns, obsessive thoughts becoming dominant sometimes, or at other times a generalized worry takes a leading role, depending on influences external and internal?
Thanks, Paul. Yeah, I didn't even mention Tyrer's Tyler's thesis for his proposal of a general neurotic syndrome, which definitely was not adopted, but I think has informed research, just getting people to think about these things the way we've been talking about them today. But the time aspect was one thing that Tyler was particularly focused on. I think frustrated with the changeability of so-called neurotic conditions compared to conditions like schizophrenia and manic depressive illness. So over time, and I think one definitely does see that different symptoms become more prominent at different times, and certainly patients develop depressive episodes, particularly if they're not being treated.
Okay, last point. I guess it's a point rather than a question, but from Ray to Paulo. Joe, great review of the clinical histories of rare disorders. Early in DSM-5 meetings, there was a plan to have a schema for all psychiatric conditions, and it was to divide all of psychiatric conditions into internalizing versus externalizing. And Ray says, very interesting as to how this failed the sniff test of the committee.
Yeah, no, I think it just like the four humors understanding of the world. I think we sort of scientists and clinicians are prone to try to oversimplify things, just as I have done today.
But you did magnificently.
Thank you so much.
No, that was great, Joe. It was really, really fascinating. Thanks everybody for joining us. Take care. Next time in person.